I'm Professor Dr. Bela Shah, working as head of the department at BJ Medical College. So today I'll be talking on pruritus. So what is pruritus? It is an unpleasant sensation which elicits a desire to scratch. And it is such a common symptom in dermatology practice, right from infancy to senile age group. It is a very common symptom to address and deal with. So if you see an infant rubbing his cheeks, that is again a sign that child is experiencing the sensation of itch. The itch reflex is not developed very well in infancy, but you can see infants rubbing their skin with the pillow or anything else. So that is when the children have or the infants have eczema on the cheeks, which is called infantile eczema, or which is manifestation of atopy or atopic dermatitis. So there are plethora of causes, and each can be localized, each can be generalized, it can be acute, it can be chronic. And I have seen patients who present with intractable pruritus, and nowadays we have patients who walk in with recurrent refractory dermatophytosis, and this subset of patients also have predominant symptom of pruritus. If I enlist the causes of pruritus, maybe the 90% of the dermatosis in dermatology evoke pruritus as major symptom. A mosquito bite, a simple mosquito bite will generate itch response very quickly, which might douse within no time. But then that symptom is quite irritating for anybody to experience. So the causes are multiple, and it will again depend on the age group, on the site of itch. Say for example, a patient who is diabetic can have neuropathic itch on the scalp or on the interscapular area. A patient of psychogenic pruritus can have generalized pruritus and the skin is absolutely fine. And there are number of inflammatory dermatoses wherein we see pruritus as a major symptom, like lichen planus, psoriasis, all subset of eczemas including atopic dermatitis. There are so many pruritogens like histamine we focus upon, but then histamine is not the only one which incites itching, but there are plethora of agents which are now labeled as pruritogens, including number of cytokines like interleukin 4, 13, 31 in context of atopic dermatitis. So we need to remember that antihistamine is not only one which targets the itch, which is very common manifestation in skin diseases. So if we look at the pathway of pruritus, it can be peripheral pathway of pruritus or it can be central. So there are so many systemic diseases like liver diseases. A patient of jaundice can present with pruritus, and when you look at his eyes, you can tell that the patient has got jaundice. So there are so many systemic diseases including malignancies which can manifest as pruritus. So as a consultant dermatologist, we should be well versed with the list of pruritus, etiology of pruritus. If I tell you, pruritus is also a very common symptom which is seen in physiological condition like pregnancy. The patient can have pruritus at second trimester, third trimester, and there are so many diseases which can occur even during pregnancy, which is going to result into intractable pruritus, and that is intrahepatic cholestasis of pregnancy. So at every stage of life, itching or pruritus is very common symptom with which patient walks in any dermatology OPD. So we should be very confident, and we should be knowing the pharmacokinetics and dynamics of not only antihistamines but other drugs which will target the specific pathways of pruritus. Say for example, if the pruritus is of liver origin, if the pruritus is of renal origin, if pruritus occurs in pregnancy, the drugs are different. Of course, antihistamines might help by having their sedative effect, especially in atopic children. When you write hydroxyzine, the baby is going to sleep and the parents will be comfortable. But we know the pathway of itch, which is through IL-31, is not being targeted by writing antihistamines. So there is more beyond antihistamines, and I would like to talk about hepatic pruritus as well as pruritus which occurs in chronic renal disease, which usually does not respond to antihistamines. We might have to use rifampicin for hepatic pruritus. We have to use ursodeoxycholic acid for pregnancy pruritus. And for renal pruritus, we have to use opioid antagonists like naltrexone and so many other drugs. So we have to understand the pathogenesis of pruritus in a given case, and as per the clinical findings and etiological findings, we should be prescribing the drugs as per the manifestation in a particular case. And there are certain entities, pruritus ani, pruritus vulva, which is very common, pruritus vulva in perimenopausal women as well as menopausal women. So we all know what are the causes why these women have itching around that time, because there is drastic reduction in the hormonal level. So there is so much to pruritus that you cannot sum up in a short video bite like this. So you have to take appropriate history, try to shortlist the clinical findings and do appropriate investigations if they are required, and use the correct therapy, and that will work like a magic in your clinical practice. Thank you.
For more such videos, visit or log into dermavidya.com.